earlier, and intervention being IV ferric carboxymaltose, and the control being oral ferrous sulfate. And the primary aim, if you can look at the left part of this flow chart, is effectiveness. We wanted to find out if one is ferric carboxymaltose is more effective than ferrous sulfate. And we measured clinical outcomes amongst the pregnant women and the infants. Our primary outcomes were the proportion of the women that had maternal anemia at 36 weeks gestation, because we recruited them between the gestational ages of 20 and 32 weeks. So at least 4 weeks after 36 weeks gestation, and also the proportion that had preterm delivery. And then our secondary outcomes were safety, severe maternal events, infant outcomes like birth weight, and maternal depression. Now, for the right side of the flow chart, you see that the other part was implementation, because don't forget, it's a hybrid effectiveness implementation design. And our stakeholders, when you are doing implementation, you are usually, your participants are usually many stakeholders: healthcare personnel, people working, the doctors, nurses, community health workers, people that are working with the pregnant women, the actual pregnant women and their partners, and their matriarchs and people that look after them, their relatives too, health facility managers, state government health officials, and other health policymakers. And the outcomes that we looked at were acceptability, feasibility, fidelity, and cost effectiveness. And these are some of the data we collected for the implementation aspect and from whom. So for the acceptability, we looked at facilitators and barriers at the beginning of the study and at the end of the study. And we looked at healthcare workers, pregnant women, and all those other people we mentioned. And the mode of data collection was both quantitative and qualitative. So it was mixed methods. For feasibility, we did the same thing, but feasibility, since it's the ease of using the product or intervention, we look at is the healthcare workers that we're looking at in that case, and we used quantitative survey. Fidelity, it was during the study, and it was healthcare workers, since so they are the ones delivering the intervention, and we used both survey as well as qualitative. And cost effectiveness, during the study and the end of the study, we have to look at it from the view of the pregnant women, from the hospital, from the healthcare workers, and cost survey and logbook are being used for those. So how do we actually go about, just briefly, I know we cannot really go into implementation science, fully here, but if we want to find out how to go about it, you can't just sit down in your office and say, oh, what are the problems? Let's try and solve it this way. You need a framework, and there are many frameworks for implementation science. You need a framework as a guide. And one of the most common frameworks used, especially when you're trying to look at a particular context, is the Consolidated Framework for Implementation Research, known as CIFAR. And this was first thought of by Dan Schroeder in 2009. So for the CIFAR framework, it helps you determine the context. It helps you also design the questionnaires that are going to use to capture your data, and also to explain and understand the context in which you are working. So for example, it has 5 domains: intervention characteristics, whatever intervention it is you're using, what are the characteristics? The inner setting, talking about the health system itself. The outer setting, the external policy environment, what individuals are actually involved, so the stakeholders, and then the implementation process itself. So the constructs are these ones in this column here: feasibility of the intervention characteristic, the complexity, acceptability, and the cost. Then whether the health system itself is ready for this, your new intervention. Will this, for us, for example, intravenous iron, is our health system ready for it? Are other health systems ready for it? The different ones, the primary health centers, the secondary health centers, and so on. And then are they ready? Will they be able to implement it? Outer setting involves external policy environment, existing policies, NAFDAC, NHIS, insurance areas, and so on. The individuals, very important, the stakeholders, the women, their partners, the doctors, the nurses. You have to take all of these people into consideration. And then the implementation strategies you're going to use, including the ones for assessing the implementation outcomes and the cost effectiveness. And all these, we now found that you can find acceptability, feasibility, fidelity, and cost effectiveness are the outcomes that we studied using this CIFAR framework. So starting from the beginning, we first conducted a formative assessment, okay? Also, CIFAR helped us determine this. Before we even started the trial, we spoke to a total of 193 participants down here at the right, and we did focus group discussions amongst a total of 140 people, and we also did key informant interviews amongst a total of 53 people. So for the key informant interviews, we were interviewing each one of all these people: women with anemia and pregnancy, traditional birth attendants, healthcare workers, community leaders, health facility managers, and government officials and policymakers. So we interviewed each one of them. Then for the focus group discussions, we had pregnant women in general, matriarchs, their mothers-in-law, male partners, and healthcare workers. We interviewed all of them in focus group discussions. And what we were trying to find out was how to better improve on our study design just with these methods. And what we found in our original study design, for example, we didn't have any standard script for counseling, patient counseling by healthcare workers. We plan to just use the consent form and then, just explain to them. But from our formative assessment, this was around COVID, and we found that there's a threat of misinformation and conspiracy theories. People will think that this drip you are giving them, you are trying to use it to change their DNA, or maybe it's a vaccine for something that is not really, you're just trying to, do something wrong to them. So because we got this feedback from our formative assessment, we adjusted our study design to create a standard patient information script to be used for all IV-iron administration, and it was to all the individuals who are involved. The same thing from our original study design, they only received the signed consent form. We found that it's important to provide clear standard reference information for both the participants and the family members. And we also created an illustrated flyer. So not just the information scripts, but something with visuals showing how it's given and describing the IV-iron procedure specifically. And this was important for the individuals involved as well as the outer setting. Then we only provided plan to provide the trainers the training at baseline, because we thought it's an intravenous iron infusion. How difficult is it to teach nurses how to just give another drip, or doctors just another drip? But when we spoke with them, they wanted it on a regular basis. And so we changed to training the healthcare workers every 6 months. And then finally, we focused just on intervention, the patient, the healthcare workers, but we found that we needed to consider all the levels. So we needed to reach, policymakers outside of our environment, and all people like the National Health Insurance people and so many others to consider the success of the matter. So what did we find? We found that intravenous iron has a high potential, talking about acceptability now, that it has a high potential to be a preferred method to treat iron deficiency anemia. It had a high acceptability rate, but we also looked at the facilitators and barriers. And for the pregnant women, they found that they wanted us to train the healthcare practitioners properly, as well as to include the intravenous iron matter into their health talk in the antenatal clinic. Health talk sessions, talk to the women, let them so as to increase their knowledge of the intravenous iron and reduce misconceptions. For the healthcare workers and the facility managers and so on, they found that there were advantages of intravenous iron to reduce anemia-related complications, and it was the preferred alternative to blood transfusion. But they wanted adequate training. They wanted us to have an uninterrupted supply, and that there should be subsidies to offset the presumed high cost of the condition. For the barriers, there were things like the cost, fear of needle pricks, fear of adverse events, and all these were addressed during the talks. What about feasibility? Feasibility is the ease of use in Nigeria, and we found that from that, using the surveys, the feasibility was quite high. They felt this was before the lighter color is at the baseline and the darker color is at the end line. So intravenous iron for iron deficiency anemia seemed easy to use, 94% baseline, 97% end line. It seemed doable, more or less the same, 98% baseline and 7% end line. It seems possible, 94%, 95%, and it seems implementable, 89% baseline, 85% end line. There was no statistically significant difference in the baseline and end line. So the feasibility was high, and it was attributed to the targeted strategies. Don't forget that this was in the context of a research setting. So they felt the feasibility was high. And for it to be highly integrated in practice, we felt that there should be adequate human resources. There should be a policy on task shifting, so that it's not just the doctors that have to give it, but also the nurses and even possibly some lower cadres once they are appropriately trained. Fidelity, like I said before, is the degree to which the intervention is given according to the protocol, or how it's meant to be given. For the fidelity, we found a moderate degree. So if you look at all the facilities, the total fidelity was about 66%. It was highest in tertiary centers, as you can imagine, because we have a lot of highly qualified personnel there. It was okay in secondary centers, but it was quite low in the primary centers. And the reasons, when we spoke, so this was a mixed method study, and when we spoke to the participants, the healthcare workers in all the centers, part of what we found was that teamwork influenced high fidelity. So when you can work as a team, doctor don't say it's because it's me that must do it, or nurse doesn't say it's me that, must be the one to do it. Everybody works together as a team. You have readily available charts and protocols that help you remember what to do at the right time, were factors that influence high fidelity. But the ones that influence low fidelity, for example, in primary health centers, the issue of high workload. You're in a place where you have so many patients, and you now have to do an additional thing again during this time. So it triggered instead of you doing it according to the protocol, you just rush it. And then also, if you don't have the drugs in the correct place where they're meant to be, you don't put them there. Maybe the drugs for resuscitation, if it's required, they're not nearby. Those are things that affect low fidelity. And if you don't have them nearby, that's also low fidelity. Then prolonged waiting time pressures for the healthcare workers, and they weren't able to observe the vital signs quickly, immediately, because they wanted to be quick for the patient. So those are some of the things that influence low fidelity. So overall satisfaction, this is close to the end now. Overall satisfaction with intravenous and oral iron treatment from the pregnant women was really quite high. For the ferrous carboxymaltose treatment, that's the IV iron, 80% of them found it to be excellent at the end of the study, compared to the oral iron treatment. As you can see, just 62% found it. So it was a statistically significant difference in those who found the satisfaction with the ferric carboxymaltose treatment compared to the tablets, which is the usual care. So we can see that our women really preferred it, the women who actually had the drugs used. So in conclusion, implementation science allowed us to proactively address barriers and enhance facilitators affecting the use of the evidence generated. It narrows or eliminates the no-do gap and promotes equitable access and use of evidence for all eligible populations. And implementation science facilitates the linkage of evidence to practice so that the benefits of new findings are not delayed, but they are quick, immediate, and they are sustainable. These are my partners. The study was funded by the Gates Foundation. College of Medicine was the sponsor. London School of Hygiene and Tropical Medicine were also involved. Karolinska Institute in Sweden, Aminu Kano Teaching Hospital, and Bayero University. I have to acknowledge Dr. Opoyemi Akianjo, our resident implementation scientist, for her help with my slides. She was really great with this. And these are some of the members of the team. This is us in CICITRIS. This is Opoyemi here, who helped with these slides. This is us in Kano during some of the trips. This is us as well. I think this was in Lagos here. And this is CICITRIS. Thank you very much for listening. Thank you.
A round of applause for Professor Bosede Afolabi. Can you hear me? A round of applause for Professor Bosede Afolabi. She is not just a professor of obstetrics and gynecology, but she's also an excellent researcher. You can agree with me that she did justice to, as the keynote speaker, she did justice to our theme, implementation science in healthcare and pharmacy practice, optimizing research and health outcomes. And she not only talked theoretically, but she showed that she's practicing it. Because she showed us her national research on anemia in pregnancy, which is with regards to parental iron, new of the usual oral administration. And she has demonstrated collaboration, innovation, and shared learning. And she has made us to understand that implementation research, in summary, is linking evidence to practice. In their work, she has shown us from traditional research to intervention and to implementation science. And they analyze their outcomes, the implementation outcomes and service outcomes, with regards to feasibility, fidelity, scalability, sustainability, and cost effectiveness. Another round of applause for Professor Bosede Afolabi. It's now time for Q&A. After that, we're just permitted to take only 2 questions, please. Those that are online and those that are here, we are going to take just 2 questions. You want to speak, sir? Okay, you come to the podium. How many people are online, please? Okay, he said we can give those online first to ask their question. After the, none. So after the question, permit me, we're going to give Professor Afolabi her certificate and plaque immediately. Thank you. Question, sir.
Can you hear me? I believe you can hear me. My name is Professor Samuel Ike. All right. Thank you so much for that presentation, ma'am. It's quite illuminating, and I think my notes is full already while I'm writing. 2 things I want to get to understand. The first thing, you spoke about the timeline for implementation science, and I'm trying to look at what are the bottlenecks. Is it the cost of the research? Is it the regulation? Is there some sort of a risk involved that might be limiting the execution of implementation science, and that is increasing that timeline? Then secondly, very interesting study that you described. I'm looking at real world data collection, and what kind of level of commitment do we have to that? So you spoke about this intervention that is in high income area. We're trying to localize to a low income area. And you will agree with me that what you've just done, even though at that stage is still controlled, when things get into the space where nobody has control, who's responsible for collecting real world data so that we can refine this intervention as we go on? Thank you.
Prof Ma, did you get his question? Prof Ma?
Yes, I did, but it looks like there's another hand up. Yes, and so that's why I'm waiting.
So unmute the person to speak. You can speak online. Professor
Yes. Thank you very much, Professor Afolabi, for a great keynote address. Yes, I'm happy that there is report that say that you can use intravenous instead of tablet. What I want to know is, this tablet is taken daily. How many times will you take this intravenous injection to be able to cover for the everyday that is used by the pregnant women? I don't know. Is it a control release that is making it possible, or Anyway, you have the answer. Thank you very much for a great work. You have not disappointed me. You know my thoughts towards you, that you are a great scientist. Thank you very much.
Thank you, sir.
Professor Familoni for that question. Now we take the last question by Professor Oruagba before Professor Afolabi answers the question. Professor Oruagba, please. Can you unmute?
Yeah, thank you for unmuting me. And I want to thank the keynote speaker, Professor Afolabi, for a very interesting presentation. Mine is a very simple one. I haven't listened to the meaning of implementation science. Can we say that clinical trial is a type of implementation science? Thank you.
Professor Afolabi, the floor is yours.
Thank you very much for those questions, those very good questions. So the first one is about the timeline for implementation science. Actually, what I was trying to point out is that the timeline for traditional implementation is, very long. That's the one that takes 17 years on average, when you don't actually factor implementation science into it. But when you factor implementation science, especially when you do it early, like we are doing for our trial, we don't expect the timeline to take that long. In fact, it's probably anything between 2 and 5 years, depending on the topic or the intervention. So on average, but in terms of the traditional one, that's the one that takes so long. The other question about it still being controlled in a clinical setting, that's true. Who is responsible for collecting real world data? It should still be the scientists, the practitioners. Apart from clinical trials, we can still try and collect real world data. In fact, we're embarking on a project soon where we're going to look at, once we found that it's the intervention is effective. And in this case, we did find our intervention to be effective. I didn't give you the results of that. It's about to be published in Lancet Global Health on the 18th of September. We're very excited about that, and we'll do a proper press release about that paper. So we found it to be effective, but the fact that it's effective doesn't mean that it will definitely be used. And that's part of why we've been doing the implementation work, looking at the acceptability. Cost effectiveness is also going to come out soon. But who is responsible for collecting real world data is still the scientists. So we plan to collect real world data in another project where we will give the intravenous iron to pregnant women, and then we will now do interrupted time series data collection, looking at whether anemia and so many of the complications that are involved reduces over time. So that's the answer to that. For number 3, how many times did you take the IV iron injection? That's a very good question, so that people will realize that the beauty of this intervention. Only once. The particular one that we used, which is ferric carboxymaltose, you only need to give it once, 1 dose, because that 1 dose has 1,000 milligrams of iron, and you can give it once within 20 minutes. So that's the beauty of it. Compared to this tablets that this woman will take 2 to 3 times a day, even if it's once a day, but she'll still take it throughout the pregnancy till 6 weeks after. So with the difference with this is that you only need to take it once, and it is safe. And then the final question of whether implementation clinical trial is a type of IS. No, not really. What I was just trying to show is that you can have a hybrid effectiveness stroke implementation trial where you are carrying out your effectiveness work, you are testing an intervention against the other, but you are also doing your implementation research at the same time, where you are looking at things like acceptability, sustainability, effectiveness, and looking at the strategies in which to measure these outcomes and hopefully eventually get them to be what's the word now? Get the proper health outcomes we want. The once daily dose. I asked about what makes the once daily dose possible. It's not once daily; it's just once. 1,000 milligrams. It's because of the amount of iron that can be given in that dose, which is 1,000 milligrams. Unlike the tablets that you're taking, you have to take it for so long before you can get that same dose of amount of iron. So it's because of the amount, and you give it just within 20 minutes, and that's it. So that's the beauty of that preparation. Thank you very much.
Thank you very much, Professor Bosede Afolabi. Another round of applause for Prof. We are now going to present the certificate and plaque to Professor Bosede Afolabi. And I call on the Subdean Faculty of Pharmacy, Dr. Foluke Ayeni, to present the plaque and certificate to the keynote speaker. Thank you. It's a virtual presentation, but we have the plaque. She will show you. She has the plaque physically, and Prof is going to get it without delay, but she wants to present it to her virtually. Prof. Thank you so much. So on behalf of the Faculty of Pharmacy, the chapter of this scientific of the pharmacy, I want to present this class to Professor Bosede Afolabi, our keynote address today, for the excellent delivery of the topic, presentation science in healthcare and pharmacy practice, science research and health outcomes. Presented today by faculty. Thank you very much.
Thank you very much. I'm really honored. Thank you.
You're welcome. So you're going to receive it without delay. Thank you, Prof, for coming. Thank you. So it's now time for the plenary session. And I want to reiterate the ground rule, just like we did for Prof. After each plenary session, we will take a few questions just for 5 minutes and present the certificate and plaque to the plenary speaker, each plenary speaker, before we go to the next one. In addition, as the speakers that are going on, you can put your questions in the Q&A box. You can, you don't raise your hand, except when the plenary speaker is done speaking. Then you can raise your hand for those that want to ask their questions orally. So that is the ground rule for now. And the first plenary speaker is Professor Ijeoma Uchebu. She is a fellow of the Royal Society of Chemistry, and she will be talking on novel drug discovery systems for optimizing healthcare outcomes. And to read her citation is Dr. Damilola Kolawole. You're welcome.
Good morning, everyone. All protocols duly observed. It's with a great pleasure that I'll be reading the citation of Professor Ijeoma Uchebu, who also happens to be my MSc Research Supervisor at the University College London School of Pharmacy in 2009. Ijeoma Uchebu is University College London's College of Professor of Pharmaceutical Nanoscience, a Fellow of the Academy of Medical Sciences, an Honorary Fellow of the Royal Society of Chemistry, a Governor on the Wellcome Board, one of the largest biomedical sciences research charities in the world, a member of the Academy of Medical Sciences Council, and Chief Scientific Officer of Nanomerics Limited. Professor Uchebu is the 7th elected president of Wolfson College, University of Cambridge, UK. Professor Uchebu is the scientific secretary of the Controlled Release Society. She is an inventor, and she has out-licensed medicines developed in her laboratory to bypass pharmaceuticals. Our company, Nanomerics Limited, is also developing medicines that address sight-threatening illness. Technologies developed in Uchebu's laboratory have won prizes from the Royal Society of Chemistry and the Royal Pharmaceutical Society. Nanomerics Limited recently won the King's Award for the Enterprise 2024 in the innovation category. The King's Award for Enterprise is the UK most prestigious business award. Ladies and gentlemen, join me in welcoming Professor Ijeoma Uchegu to take the first plenary lecture for the Faculty of Pharmacy Scientific Conference.
Thank you so much. Can you all hear me? Can you hear me? Can someone hear me?
Yes, please, loud and clear, ma'am.
All right, thank you so much. It's an absolute pleasure to be here to talk about our work, and really nice to see you again, Damilola, and to see that you're doing amazingly well. So I'm really going to talk about some of the work we've been doing in our laboratory, and also talk about some translational aspects as well. And really the focus of this particular talk is how we have used nanotechnology to solve some large pharmaceutical problems. And for those of you that are not clear on what nanotechnology is, we are looking at particles that are about 1,000th the width of a human hair. So these are incredibly small particles. And when we put drug into these particles, we have better control of where the drug goes in the body. And that really is what we're doing with this technology. This technology we've been working on for decades. And I do remember the actual technology now that we're entering into the clinic with. I do remember actually designing this molecule years ago, drawing it in my lab book before we went completely digital. I mean, such is my age that I was actually drawing with a pencil, and then deciding how to synthesize this molecule, which is now going into the clinic. So to just summarize what I'm going to talk about, I'm going to outline the problem we're trying to solve. I'm going to talk about the tools we use, and then I'm going to give you some case studies before I move on to the commercialization aspects of our work. So quite simply, what's the problem we're trying to solve? And so this is the route to drug discovery and development that we are all familiar with. And in actual fact, the previous speaker actually outlined some of the later stages of this work, clinical trials. But we, in our lab, we start from quite early in this particular cycle. So the cycle starts off with identifying the target you want to address. So this target could be a particular protein that you want to downregulate, or it can be a particular receptor that you want to suppress, or it can be a particular microorganism that you want to kill, a bacteria, virus, or other parasite. Once you've identified the target, you then identify compounds that can address that target. And these compounds will be very, very many. It is estimated that we will look at 5,000 compounds before we find one compound that will make it into the market. So for every compound that makes it into the market, there's been a screening of about 5,000 related compounds. Once we get our lead candidate molecule, we go into preclinical proof of concept, and we go into formulation. And I don't know, can you see my cursor at all? Don't know if you can see my cursor, but I'll just take a laser pointer. This is the area that we work in here. Can you see the laser pointer? Great stuff. So this is the area we work in formulation. Trying to see if I can reduce the, move you out of my way. Okay. And then after you've done the formulation, you have to do regulatory toxicology in 2 species. These studies alone, when we did them, they were about £1 million, but now they're about 2 to 3 million pounds to do the regulatory toxicology studies. And then you do your GMP production to get your drug product, and then you go into phase 1. And so we are now working in this area here, and we're actually started manufacturing our GMP drug product. So that manufacturing should take place over the next few days. So it's quite an exciting time for us. You do the phase 1 where you're just looking for safety. Then you do the phase 2 studies where you're looking for efficacy in humans. And this is the most perilous phase. The phase 2 is the most perilous, where a lot of drugs fail. And then phase 3 studies. Now, I've told you that it's 1 in 5,000 compounds at this stage. When you get to the clinical stage, it's 1 in 10 compounds that make it to your new drug application. So this is a very, very expensive, slow and risky process. It takes about 15 years and over £1 billion sterling to get from concept to marketed drug products. You have failures along the route. 90% of clinical drug development trials fail. Most of the trials are in phase 2. And a lot of those failures can be actually focused on poor target tissue exposure in the clinic. So if we can improve target tissue exposure to the drug molecule, we can have an impact on those failure rates. The other issue that we face is that patients do not take their medicines. And I was really excited to hear about the work around implementation to see whether new technologies, interventions will actually be taken up, not just by caregivers, but also by patients. And what you find is that even after approval, there is very poor patient adherence. And 125,000 deaths in the US every year are attributed to poor adherence. And when you ask patients, they are very afraid of adverse effects. They're scared of the side effects. And I know someone who had a stroke who doesn't want to take medication because of a fear of the side effects. So what we're trying to do is solve the problems of drug development failure and patient adherence. And now I'm going to tell you the kind of tools we use. We use nanoparticles. This is an electron microscope of the nanoparticles that we use. We try and see whether we can deliver drug to hard to deliver areas such as the brain. The brain is hard to deliver to because of the blood-brain barrier. It's hard for drugs to cross from the blood into the brain parenchyma due to things like the anatomy, the way the drugs are degraded when they achieve close proximity to the blood vessels, and also due to the fact that if the drug is polar and hydrogen bonding with the water in the blood, it has to break all those bonds to enter into lipidic membranes, which is a high energy process. So drug delivery to the brain is difficult, and drug delivery to the bladder is difficult. I won't show you the case study where we were able to deliver drug to the bladder, but because the bladder is continuously voiding, drug delivery is difficult. Drug delivery to the retina for sight-threatening diseases is also very difficult. And currently, patients with retinal diseases for which there are treatments receive an injection into the eyeball. If you consider someone approaching you with a hypodermic needle and to inject into your eyeball, I feel already that this is quite traumatic. We can also deliver not just to specific cells, but to specific cell organelles. This is the work we've done over the past 25 years. So let me give you some case studies. And one of the first case studies I'm going to give you is trying to deliver genes to the brain. Remember, I said that for drugs to go into the brain from the blood, they have to remove their hydrogen bonding with water, pass into the lipophilic cells of the brain endothelial cells, the brain capillaries. They have to pass through the brain capillary cells into the brain parenchyma. For that, you have to be a small drug, less than 400 Daltons, with lipophilic functional groups. With a nucleic acid where you have the phosphate groups, fully ionized, millions of Daltons, this is well nigh impossible. But we've been able to achieve this, and I'll show you how. So this is the blood-brain barrier that I described. You have tight junctions. This is a cartoon of a capillary within the brain parenchyma here represented in yellow. And there are tight junctions between these endothelial cells. So molecules cannot go between the cells. They cannot go through the cells because you have pumps here on the surface pumping drug out. And then you have, of course, these molecules hydrogen bonding with the water of the blood. Very difficult to transfer drugs from the blood to the brain. And this, of course, is a problem because we have many diseases that we have to treat. And people talk about things like neurodegeneration, but there are diseases that we are very, very familiar with, like epilepsy, chronic pain, brain tumors. All these are very difficult to treat because of the blood-brain barrier. So what I'm showing you here is data where we have actually been able to deliver a gene into the brain of these animals. And the signal you see in the brain is evidence of gene expression. So we have delivered the gene by going through the nose, because at the top of the nose, there's a window of opportunity into the brain because we have neurons there to help us with smell. So what we've done is that we've packaged the gene into particles using the polymer you can see here. And we've then used that to deliver the gene into the brain and achieved gene expression. You have a clear dose response. So when you're giving 20 micrograms per kilogram, you have a small signal. When you're giving 100 micrograms per kilogram, you have a higher signal. So we know that we are delivering these genes into the brain. And we were the very first to show that actually we deliver into the cerebral cortex. That's where we have our delivery happening, into the cerebral cortex and the front of the brain. So it goes through the olfactory bulb and you can target the cerebral cortex. And this is shown here. This is the data itself. And what you can see is you have very high levels in the olfactory bulb, you have high levels in the cerebral cortex, and you have lower levels comparatively in the striatum. This is our delivery system. This is a commercial in vitro delivery system that we use as a control. And this is when you use the plasmid on its own. You see that you hardly get any gene expression. Here, we've delivered the gene, and then we've waited for the protein to be transcribed and also to be translated, and then we measure protein levels. So we were the first to show that we can really target the cerebral cortex, which is important for some diseases. We've started commercializing not the gene therapy, but other types of therapeutics. And we have a delivery device that we can use in patients to deliver these genes to the cerebral cortex. So what we wanted to find out was, once we can deliver the genes, can we actually get a pharmacological response? In the previous slides I've shown you, we're actually using a reporter gene, which is a gene that we can measure the protein because the protein shines a light, so we can measure it. But can we achieve gene therapy that is therapeutic? So this is a little bit of a complicated slide, but just bear with me. What we decided to do was to downgrade a particular protein that leads to proliferation of cancer cells. So when you have DNA damage to your cells with sunlight or chemicals, such as the chemicals found in cigarette smoke, what normally happens is that you upregulate a protein called P73. This P73 protein, once it's upregulated, you end up with apoptosis. And apoptosis is when cells die of their own accord. It can be triggered by this p73 protein. But you have some other oncogenes, they're called, and what these do is that they downregulate p73. So when you get DNA damage, you don't have these cells dying, but you have them proliferating. So what we thought is, can we downregulate this particular gene, which is called itch, which downregulates p73? So 2 negatives, of course, will give you a positive p73 being upregulated. So we're going to downregulate itch by using a process called gene silencing. Gene silencing is when you give a piece of ribonucleic acid that targets a gene and causes that gene not to express its protein. In fact, the messenger RNA that comes from that gene is destroyed. So that's what we're trying to do. We're going to deliver this gene silencing ribonucleic acid. We're going to downregulate itch. We're going to see if that upregulates p73 and causes cells to die. And this is what we did in vitro. So first of all, I'm showing you in vitro data. We have, if you look at this part of our Western blot here, what you can see is that when you compare itch with the control itch that hasn't been downregulated, you can see that we've downregulated the itch with this particular piece of sRNA, this particular piece of gene silencing RNA. And what we've also done is that we've been able to upregulate p73. This is control p73, and here the band is a little bit darker, so we've upregulated p73. And then if you just follow this row here, what we have, this is just looking at the nucleus of cells using a confocal microscope. This is looking at dead cells when we apply the downregulation of itch. You see more dead cells. So the cells are dying. And when you see more green cells, they are dying by apoptosis. So you can see that it really does work compared to the control. So this is our therapeutic. This is the in vitro control mechanism method of delivering the gene silencing, and this is ours. And you can see that you really do have cells dying and cells dying due to apoptosis compared to the control. So we know it works in the cells. Now we have to find out, does it work in the animal? So the strategy, we have an intracranial tumor, we inject into the animal, and then we add our materials. Saline, no treatment, just downregulating itch, adding chemotherapy through the nose, everything is going through the nose, adding chemotherapy and downregulating itch. Then we follow the animals. This paper is actually published, so this is an out-of-date slide. Paper's been published already. And this is what we find. When we have saline, the animals survive for 29 days. The tumor is big and proud coming out of the brain parenchyma. If we downregulate the protein and upregulate p73 and cause apoptosis, we were surprised. We only get a small increase in survival, and it's not even statistically significant. So on its own, causing the cells to die with silencing the itch and upregulating p73 gives you a marginal effect. When you have the chemotherapy, you have a larger effect, and that's this blue line here. But it's when you have both, you have a really phenomenal effect. So you've added the chemotherapy, it's caused DNA damage. You've then made sure you've got a lot of p73 to cause the cells to die. And that's your best case scenario. We actually increase almost double survival in these animals. So it does work, but it works not as we had initially predicted, but it works when you consider the whole theory. And then I'm going to talk to you about the oncology platform we're developing as well. And we're focusing here on triple negative breast cancer. This is breast cancer that doesn't respond to hormones and doesn't respond to antibodies against the HER2 receptor. Those of you working in breast cancer know that you can treat breast cancer with hormonal therapy. You can also treat it with a monoclonal antibody called Herceptin. If you don't have any of those, then you have very poor survival in breast cancer. In the UK, 5-year survival for breast cancer is very good, 98%. But triple negative breast cancer survival is poor. And if there's metastatic, then it's really just palliative care. So a lot of patients globally, 8,000 new patients every year in the UK. I couldn't find data for triple negative breast cancer patients in Nigeria, but I do know it's more common in Black women than white women. And there are particular receptors that are expressed called CD44 receptors that are overexpressed in triple negative breast cancer. So we made an oncology platform that targets CD44 receptors. That's what we did here, using albumin as our base. And this is, you can see a picture of the nanoparticles here loaded with drug. And what we found is that absolutely, when you have these targeted nanoparticles, they are taken up, and you can see they're taken up with all the green, they are taken up by CD44 receptors. If you don't have the targeting, there's poor uptake, so you have less green in the cells. And we also were able to show that they're taken up by cancer stem cells. Those of you that work in oncology know that there is a resistant population of cancer cells called cancer stem cells that don't respond to therapy. And they're the ones that cause the resurgence of the cancer. So here, what we show with the green here, when we look at the targeted versus the non-targeted, is that we really get these nanoparticles that we designed taken up by these breast cancer stem cells. And this is the money shot, really. We show that when we treat the tumors with this targeted material in the mouse, so we start off with the tumors growing in the mouse, and we start treating them once the tumor is a suitable size. If we don't treat them, the tumors grow. If we treat them with current standard of care, tumor growth is delayed, but it's only when we treat them with our system that tumor growth is completely obliterated and there is no resurgence. And we believe there's no resurgence because we are getting to the cancer stem cells. And this is currently a paper under review. Commercialization is the last part of the talk I'm going to talk about. So as you heard in the introduction, we have a company called Nanomerics. We've won prizes. And this year we won the KINS Award for Enterprise. We had a lovely ceremony last Friday where the Deputy Lord Lieutenant representing the King came along and presented us with our crystal, which is a mark of the prize. And one of us, not me, went to Windsor Castle to meet the King. So yeah, I'm still not very happy that I didn't go, but such is life. So we have an excipient that I told you, I remember designing, drawing the structure, and we have an active excipient. We can control where the drug goes, very different from off-the-shelf excipients. And we're using this to target brain diseases. We have a therapeutic we've out-licensed to a company in the United States, and we're targeting the opioid crisis. It's a pain therapeutic. In the UK, 40 people die every week from opioid poisoning. In the US, 80,000 deaths a year from opioid poisoning. 15,000 of those are from prescription opioids. The clinical trial we're doing at the moment is an ophthalmology, where we're going to look at allergic conjunctivitis, severe allergic conjunctivitis, for which there is really no topical treatment. And we also work in the oral route. Our technology is called the molecular envelope technology. It's a self-assembling polymer, but it's an excipient. And this is our pipeline. We have a number of assets that we're developing. We've out-licensed some of them, and we're working on some of them on our own and working with different companies. And just to demonstrate what we can do with the technology, this is one of our eye drops. And you can see we get high levels compared to commercial formulations in the conjunctiva and cornea but we don't get any of the drug in the blood. And that's really, really important because this is a very potent drug. So we really do have targeting by using these nanoparticles. And this is the phase 1. We'll get phase 1 data this year. We received a fast-track passport from our regulator, Medicines Healthcare and regulator. And this fast-track passport is because of the innovation and the patient need. We're working with partners. Pace are manufacturing for us, and Quotient are doing the clinical trial. We can also deliver drugs to the retina. Instead of using the needle in the eye, we're going to use eye drops, and we're targeting dry age-related macular degeneration. We know it will work because this particular act worked in Stargardt's disease, which is a form of macular degeneration. And so we're going to test this in a trial with a collaborator in Florida. Our technology is really differentiated from others, principally because it's a penetration enhancer, which is non-irritant. And we have the world's only non-irritant penetration enhancer, and we can say that. So just to summarize, I hope I've been able to convince you that we can deliver nucleic acids to the brain and treat neurological disorders, that we can target cancer stem cells, and we have an asset which is indicated for triple-negative breast cancer. I didn't talk to you about our pain therapeutic, but it is a peptide, which is labile. We can target drugs to ocular tissues with no plasma exposure, and we can deliver to the retina using eye drops. This work is definitely not a single person event. I'm literally presenting work. I haven't touched a piece of lab equipment for about a decade. So I've had to rely on colleagues, students, and postdocs and various collaborators to do this work. So I'm just the messenger, but I've worked with excellent colleagues all over the world, and really collaboration is the answer if you want to do impactful work. Thank you very much for listening, and I'm happy to take questions.
Wow, wow. A round of applause for Professor Ijeoma Ucheku. As the Scientific Secretary of the Controlled Release Society, she excellently delivered that lecture titled Novel Drug Delivery Systems for Optimizing Healthcare Outcomes. Yeah, and she demonstrated that drug delivery to the retina, which is her focus, is difficult but doable. And she gave us 10 studies. One told us about trying to deliver genes to the brain, and they succeeded in that. And also, she's into oncology research, with emphasis on triple-negative breast cancer. Yes, Professor Ucheku is not only a professor of statistical nanoscience, he's also an inventor and entrepreneur. Our company developed a novel commercial in vitro delivery system. A round of applause for Professor Ucheku. Now it's time for question and answer. If you want to speak and you are virtual, you can raise your digital hand. But in the meantime, we have a question in the chat box for Professor Ucheku. And it says, I think that getting chemicals that will not naturally get into the brain from the blood is exposing the brain to some toxicity that would be difficult to evaluate. Prof, what is your take on this? And the question is from Chief. I'm sorry if I didn't properly give your name by your title. It's how you label your name. I said the question again, Prof.
Yeah. Oh, okay. I got it. Did you want me to answer them one by one?
We have another question. You can answer this, Prof. Yes.
Okay. So excellent. What you have to do before you go into the clinic is that you have to establish that there is no toxicity. So we have done those studies. We've dosed intranasally, and then we've measured in a GLP, which is a good laboratory practice study, and we've looked for toxicology, and we've identified no toxicology at the doses that we use. So we have a no adverse effect level for our delivery system of about 18 milligram per kg in the rat. And our collaborators also have done this work. There's the people that we out-licensed one of the medicines to. They've also done this work. So you have to do the toxicology before you go in to try and do clinical trials. The most important thing is that we get the pharmaceutical molecule into the brain, which is what we want. And we're not opening the brain to all sorts of toxicology because we're going through the nose. And so long as we get the pharmaceutical material into the brain, that's what we actually want. And we've studied the toxicology as well.
Thank you so much, Prof. We have so many questions coming in for Professor Uche. I will just run through the three questions now, and Prof will take them together, please. 3 questions. The first, another one by Dr. Arinola Jordan. He said, very excited to see these various collaborations. Prof, how these collaborations between academia and industry begin? The next question says, that is by Okebuzu Otulo. It says, please, what is your thought on using nanobots and smart devices in drug delivery? And the last question says, that is by Dr. Uloma Ukubani Goma. It says, what type of ocular topical formulation do you use to deliver medication to the retina? I'm aware topical formulations have poor bioavailability in the eye. Thank you, Prof.
Right, thanks very much. So I'll take them one by one. So the first one was collaborations. So with academic collaborations, it is about going to conferences, meeting people, talking to people when you go to their poster or after they've given a talk, and just talking about how you would be able to complement their work with your work. That's how we find collaborations, normally at conferences or partnering meetings. The key thing is with collaborations, which people seem to underestimate, is that people collaborate with people they like. So it's very important to be agreeable and open when you meet such people, so that, you know, if you want a particular collaboration, you're more likely to get it if there's complementarity, but also if you find that there is mutual respect and you like each other. We tend to underestimate the fact that you have to like each other to collaborate, but it is actually quite important. The other one was about nanobots and smart devices. So nanobots, I'm not really sure what they are, I must admit. It's not something we use in our laboratory, so I'd need further explanation there. We do some device work. So we were working, for example, with gold nanoparticles to try and develop some diagnostic devices. And this was a very big collaboration that we had over 6 years with physicists. And we went some way to developing some of these devices. And then someone talked about delivering to the retina. You're absolutely right. It is currently not possible to deliver drugs to the retina using eye drops. We work with the rabbit model, which is a good representative of the human eye, both in size and anatomy. And we've been able to do that. And the key thing is that because of the penetration enhancement, you have the drug entering into the sclera. Once it gets into the sclera, it gets into the choroid, and then through the blood circulation, it then gets into the retina. We've been able to show this.
Thank you so much, Prof. Please permit me to take the last question by Ikonferi, connecting from the University of Rwanda. And it says, Prof, thank you, Prof. Is the upregulation of P73 to induce apoptosis selective for the cell, or can also affect normal cells in the brain?
Yeah, so what we haven't done, we have shown, for example, in a different study, which I didn't show here, that when you take all of the brain and you look for the downregulation of itch and the upregulation of P73, we find that in the brain. What we haven't shown is that you are going to get that specifically in the tumor cells in the brain, because we didn't distinguish. But the thing about the upregulation of itch, this is normally associated with cancer. So it's because this is a cancer-specific type of upregulation, if you downregulate itch and you upregulate P73, you're more likely to hit the cancer cells.
A round of applause for Professor Uche for doing justice to all the questions. Thank you so much, sir. We are honored to have you. Now it's time to present our certificate and the plaque. And to present this is Dr. Ariola Jordan, presentation of certificate and the plaque. We have it here. We'll present the copy. Thank you very much. Thank you very much, Professor Uche, for your well-researched presentation. And I have a co-presenter here with me. Dr. Akile seems to be my running mate in this assignment, but it's all good. So we're presenting this award plaque to Professor Jamal Chegu, first plenary speaker for this third Faculty of Pharmacy Scientific Conference. A very well thought out, well researched, and very exciting presentation on what we are currently doing, and which is opening our eyes within the academic community on collaborative activities within industry, with the theme implementation science in healthcare and pharmacy practice, optimizing research and health outcomes. We're grateful for your service. Thank you so very much.
I can't hear you at all.
I came here purposely to join so that I can see your face again.
Oh, how are you?
Yeah. So I appreciate you and thank you so much for allowing me to use your lab. Thank you so much. I also present it again to you. Faculty of Pharmacy. Thanks so much.
Thanks so much for having me.
Yeah.
Another round of applause for Professor Uchegu, Ijoma Uchegu. Thank you, man. When we call on you next time, we know you answer us. Thank you so much. It's now time for the second plenary speaker. And he is Professor Tony Waka-Udeze, a member of Pharmaceutical Society of Nigeria. And he will be speaking on innovative approaches to advancing evidence-based pharmacy practice. And to read the citation of Professor Tony Waka-Udeze is from Joseph Oise Oraido. Thank you. Professor Antonio Davis, can you come on your video?
It's on. I've turned it on.
All right, thank you very much. Professor Antonio Waka-Udeze, Professor of Clinical Pharmacy at the University of Illinois. Career features broad academic and professional roles, including extensive research and leadership within the pharmaceutical healthcare sector. His expertise time in pharmacoeconomics, drug therapy, and health outcomes. Professor Udeze's work includes critical consultancy for global organizations like United States Agency for International Development, the NCDC, and the Federal Ministry of Health. He's also involved in educational activities, including
An external examiner that zero, then okay, that's how you make public health policy and health education continue to have substantial impact both locally and internationally. Ladies and gentlemen, yes, I'm very I present to you Professor Antonio Laka.
Good afternoon. Thank you very much for inviting me for this program. I am happy to be with all of you today. So my name is Professor Tony Waka Udezi. And the title of my presentation is Innovative Approaches to Advance Evidence-Based Pharmacy Practice. I am from the Department of Clinical Pharmacy and Pharmacy Practice at the University of Benin. This is the outline I want to use for this presentation. First, I will have a little mention of evidence-based pharmacy practice, then look at the key principles of evidence-based pharmacy. What role can digital technologies, electronic health records, and even pharmacogenomics play as far as evidence-based pharmacy practice is concerned? Of course, when talking about evidence-based pharmacy practice, we need to pay attention to adherence strategies, because no matter how skillful the pharmacist is, without adherence from those who benefit from his clinical skills, then the proper results will not be obtained. Then we will look at the strategies that we should follow in order to establish an innovative practice that rests on evidence. Finally, we will conclude. So we are talking about evidence-based practice. What is the key goal? What is the idea that is behind evidence-based pharmacy practice? The goal is actually to improve the quality of care for patients. When you improve the quality of care for patients, are the tools that you are going to use in improving the quality of care safe for the patient as well? That is a pertinent question that must be addressed. So both the quality of care and the safety of the patient must be brought into focus. If we bring this into focus, then we should now start thinking, does the pharmacist have the clinical expertise? What does the patient actually think? What is the perception of the patient as it relates to his disease? And where does the evidence direct us to? So there are three key principles of evidence-based pharmacy practice. The clinical expertise of the pharmacist that looks about both the skills and the past experience that the professional has as a pharmacist, and then patient preferences and their perception towards their own disease and what they expect to benefit by interacting with the pharmacist. The best evidence that is available must have been critically examined and found to be relevant to the type of care that a particular patient needs. The integration of all this is what will help the pharmacist to be able to improve outcome for his clients. In order to help us synthesize this evidence, we must fall back to the use of digital tools. Why are we falling back to the use of digital tools? because it will help us to improve the quality of the decision that we make. So we begin to see softwares that can help us to make recommendations in therapy. We begin to look at electronic records, which are integrated systems for storing patient information. Again, we can look at mobile apps, which can help us to remind patients that, look, this is what you are supposed to do. Okay, so these tools can indeed help us to improve how well we educate the patients about their disease conditions. At the same time, we have clinical databases that help us to synthesize evidence in such a way that we are not only familiar with the current discoveries that research is putting out there, but what are the current clinical guidelines that experts in a particular field have been able to put together that, yes, despite the various evidence out there, this is exactly what works. So the fact that information is current does not necessarily mean it produces the best benefit for patients. So it requires critical examination and experts coming together to say, yes, based on the evidence that is available to us, it is this approach that works. So in the light of that type of synthesis, we use that information to now develop clinical tools or digital tools. Now, these digital tools can be integrated to one another. Though some can stand alone, but when they stand alone, they actually don't give us all the possible best experience that we need when attending to the patient. Now, evidence is there to show that telepharmacy have a role to play when it comes to providing pharmaceutical services to those who live in remote areas. So a pharmacist that is located in another location can actually supervise not only the dispensing of pharmaceuticals to patients, but can engage in clinical practice by interacting with the patient and by interacting with staff that are not necessarily clinical pharmacists, but are in the location of interest, helping to dispense medication to the patients that are in a particular remote area that are underserved. Okay, so video conferencing, okay, can be set up in such a way that the pharmacist that is located far away from that rural area will be able to see the medications that are being dispensed to a specific patient and be able to talk to the patient on the best approach to deploy his medication in order to optimize his or her therapy. The evidence is there to show that these have been very helpful in the management of both hypertension and diabetics as well. So artificial intelligence appears to be the rave of the moment. So if you recall, I did mention digital tools first before I start talking about telepharmacy. Now, artificial intelligence integrated within the digital tools can help to improve medication management, in the sense that artificial intelligence can use algorithms that are fed with specific characteristics of each patient and what is already known from evidence concerning their ailments. And these algorithms will help us to arrive at decisions that improve therapeutic outcomes for patients. For instance, artificial intelligence can help us to predict which patient is likely going to become morbid within 6 months. So before the morbidity happens, you already know that, okay, in about 6 months' time, we're going to have about 30 patients of our patients that will require hospitalization. So we begin to prepare for them. So when they require hospitalization, what are the specific pharmacy services that they are going to need? Do we have all the materials they need? Do we have the specific clinical skills that will help us to attend to all these new patients that will be under our care? So in terms of being predictive, helping us to know the morbidity and mortality pattern that is going to occur even before they occur. All those patients that are at high risk for developing complications as a result of their current ailment, artificial intelligence play a high role. It also have a role to play when it comes to clinical decision support. I did mention algorithms. Now, when we have these algorithms well integrated into our electronic records or our prescription software or our apps or into our mobile health platforms, we will see a situation where when you are entering the prescription for a patient into your digital platform, the platform will flag a drug-drug interaction for you. And a possible adverse drug interaction as it relates to a patient's medical record could also be brought into the fore for you to pay attention to what is likely going to happen next. So these integrations in the electronic health records, okay, can go a long way, not only to get you clinically prepared based on the real life evidence that is right before you, but can ensure that patients are well taken care of. So when we talk about mobile health, we are looking at mobile devices that can help us to monitor the health of patients online. Okay. Now, some of these devices might actually be patches that can be attached to a patient's skin. And the readings from the patient will be sent to a remote location where the use of artificial intelligence will help to say, oh, based on the blood glucose concentration of this patient is not benefiting from the medication that they are currently taking. So what artificial intelligence is actually doing at this point is looking at the evidence that is already existing, that has been previously critically examined, compared to the specific data that is coming from this particular patient. And then it's using it to make a clinical decision that will now guide the next step of action that needs to be taken as it relates to the patient's medication. Now, this mobile health can help us not only to play roles in educating the patient for them to become active in managing their own health. They can actually guide us in knowing the specific way to communicate and the specific peaks of educational pattern that we need to use to approach specific patient categories. So mobile health does not only help in digital medication decision-making, but supports educational purposes. And I must tell you, not only for the patient, but for the professional as well. In addition, apart from tracking the specific medication parameters of a patient, it would help to track adherence as well. because it is expected that if a patient is adhering to their medication, the parameters such as the blood glucose concentration or the blood pressure measurements are supposed to drop in a specific way. So it can easily help us to flag out those patients that are not complying with their treatment. So that is extremely important as we begin to look at the various evidence that are available. Now we have seen some form of explosion in the use of wearable technologies, electronic wristwatches. Now, these wristwatches, they have the ability of measuring the pulse rates, measuring the number of steps an individual takes in a day, and even measuring the sleep pattern of the wearer. They also can record the blood pressure, the oxygen concentration in the blood. So when you put all these parameters together, you can predict that in about 2 weeks' time or in 6 hours' time, this patient is likely going to have a heart attack. So you don't wait for the heart attack to happen, but you begin to now actively take action in order to prevent it from happening by making sure the patient is at the right place where they will get help when this kind of event happens. So they help us to track the signs, the activity level of each patient in real time, as they provide feedback not only to the patients, but to healthcare providers, especially if they are integrated with artificial intelligence and Wi-Fi that transmits the information into a central server where the processing of the data is located. So this has already been shown to be effective in the management of chronic conditions. Again, when we use mHealth wearable technology tools, we are actually also empowering the patients to take more responsibility, take control of their health. We have heard of blockchain technology. And most times when we hear about blockchain technology, we begin to think about cryptocurrency, Bitcoin, and the financial industry. But if we understand the basic technology behind blockchain is immutable in the sense that you cannot easily hack it or crack it. So if we store patient medication records or electronic health records in blockchain, we will see that the data cannot easily be interfered with. I've had an experience where I was supposed to design some form of patient medication record for a firm that have different locations, Lagos, Port Harcourt, Kaduna, and so on. But they were worried that if such a platform become active, if somebody takes drugs, is prescribed drugs in Lagos, they cannot go back to Port Harcourt and receive that same drug, because once their name is entered into the system, it will quickly show which medications they have taken in Lagos, and therefore they can no longer access any form of treatment. While it would have been easy for hackers who are experts and specialized to hack such a simple online system, it becomes virtually impossible to hack the blockchain. The electricity that is needed to run Lagos for 1 year might be needed to be able to hack a blockchain. So the hacker will ask himself, what am I going to benefit by putting in so much resources? So the benefits will not be worth it. So that has helped blockchain to be immutable. So because it is immutable, information sharing as it relates to patients among healthcare professionals is not the only benefit that can come from there. And the fact that the information cannot easily be changed, it makes it to be transparent and traceable to a source. Data integrity is therefore guaranteed. So in a situation where data integrity is guaranteed, we can then apply this technology to secure the supply chain of healthcare commodities. In the sense that we can have a barcode that is affixed on medications in such a way that by scanning the barcode, it will immediately go to the blockchain and confirm when this drug was manufactured, where it was taken from, and where it's expected to be at any particular time, and whether the drug has expired or not. All that can be developed using blockchain. Then comes virtual reality. Remember that when we talk about evidence-based pharmacy practice, I pointed out 3 basic principles that we should bear in mind. Clinical skills of the professional, the patient values, and then the available evidence. There are lots of journal publications. So using the evidence that is synthesized, critically examined from those journal publications, we can develop virtual reality applications that shows us specific patients, okay, that we want the pharmacist's clinical skills to address. So, pharmacists, in training pharmacists with these type of specific clinical tools, we can use virtual reality to present a patient. The pharmacist will interact with the patient, and by so doing, we are training the pharmacist on how to improve his communication skills. The patient will respond, and from his response, coupled with evidence and past experience of the pharmacist can then take specific action that is expected to benefit the patients. In other words, we can use virtual reality to create virtual patients. So when you use virtual patients to train healthcare professionals, they can make mistakes that will not hurt any person, despite the fact that they are actually taking clinical decisions that affect the patients. Instead of using real patients to make these mistakes, we can do them using virtual patients. So VRO has become very important, not only in training pharmacists, but also in educating patients so that patients will understand not only their medical conditions, but the treatments, the medicines that they are receiving, and why it is important for them to abide by the guidelines in terms of when and how to take their medicines. These have been successfully applied in pain management and even in mental health therapy. Virtual reality, you see people wearing some form of goggles. Yes, that is in virtual reality. It is very immersive and it is very interactive. Now let's go to the world of 3D printing. 3D has actually been used to print a gun that can actually shoot. Yes, can actually shoot. So we can use 3D printing to print delivery systems, innovative delivery systems, such as implants, and patches. Now, these implants and patches can be done in such a way that we are able to adjust the permeability of the membranes. So any drug that is imbibed into them will pass through the membrane at a specific rate in order to deliver a required dose to the bloodstream. So anytime we want to customize a particular medicine to meet a specific patient, we can indeed consider 3D printing. So we personalize it, okay, to meet the specific evidence that we have collected from a patient. So we can rapidly create prototypes of any pharmaceutical product that we believe is going to not only improve the outcome of therapy, but will improve the economic outcome for patients. Now, we have mentioned electronic health records as part of the digital, systems that we need in order to continue to provide evidence-based pharmacy services. But these electronic health records can go further as far as detecting adverse drug reactions are concerned. We integrate the two with the evidence that we have as far as ADRs are concerned in such a way that as we are putting in more information relating to different patients, it will flag that, look, this ADRO, based on the data that I've analyzed, is likely to occur for this particular patient. And it can tell you there is 70% likelihood that it will happen based on the available evidence. So that kind of integration can be used in providing reporting systems that can advance clinical pharmacy practice for the patient. Again, these electronic records can be integrated with drug interaction tools, whether it's food, drugs, and so on and so forth. So drug interaction checkers are created based on the evidence so that potential interactions can be prevented even before they occur. What about genetics? So for pharmacogenomics, we know that there is a group of genes referred to as the SATwins. And we have SATwin 1, 2, SATwin 3, we even have SATwin 6. Now, these SATwins, drugs can interact with them in order to prolong the life of a patient. But normally, we just don't focus on prolonging the life of a patient. We also look at the quality of that life that we are giving to a patient. So we can look at the evidence that, yes, this particular drug, if it does not only prolong life, but also improve the quality, what is the evidence on how we can use this drug on our patients? So that is where pharmacogenomics come in. It's such that we now tailor the drug therapy to match a specific patient's genetic profile. Drugs are metabolized in different ways by different people as a result of their genetic makeup. So based on this evidence, what should the clinical pharmacists do when a particular patient needs to receive this type of medication? So those evidence are necessary in order to optimize the kind of therapy that our patients are receiving. And at the same time, where we know a patient-specific genetic makeup, it will help us to tailor the education that is offered to that patient. Now, several strategies are valuable in order to improve adherence. No matter your skill as a clinical pharmacist, no matter the evidence that is available out there, and no matter the tools, both digital and otherwise, variables that you have in your practice or that you have deployed, if the patient is not complying with the treatment plan, the outcome is likely not going to be acceptable, both to you as a practitioner and to the patient. Therefore, we must begin to look at the available evidence and deploy it as it relates to adherence in order to help the patient to stick to the treatment plan. So how do we do it? It is important to look at those patient education patterns that have successfully helped in making people to improve their engagement with their treatment plan. One method may not work, but others may work for different disease conditions and for different types of patients. What does the evidence say? We need to understand that and deploy those. Does the evidence support giving a medication 10 times a day? Or we have a situation where we can actually combine medications and give it as a single dose for a day, and then that will help patients to adhere to treatment. So what about using our alarm? Or we have apps, of course, the mobile health we talk about, to help patients to remember when and how to take their medication. So we need to become more innovative and creative, not only around the clinical educations that we have received, but also around the tools that are available at our disposal. Are we able to also deploy the tools in order to involve the family members of any patient that is under our care? Do we follow up? Does the tools at our disposal help us to be able to follow up? And which of the tools at our disposal has given us better outcomes in terms of improving adherence? So any evidence that is available telling us a specific tool is able to help us to patient follow the treatment plan, that becomes the tool that we need to deploy. Now, there are times when we will need to interact with other healthcare providers in order to be able to optimize the benefits that a patient receives from their treatment plan. So we need to focus our minds on working in an interdisciplinary team with the doctors, the nurses, the physiotherapists, and so on and so forth, in such a way that sometimes we don't only involve the patients in the treatment plan, but we might need to involve the physician, okay? Or even the nurse, in terms of the nurse helping to know the right time to administer a particular medication. What does the evidence say? Yeah, a drug that can be given, say 6 hourly, and we really want to stick to that plan, okay? Either because if we administer it too early, the patient can go into toxicity, or if we administer it too late because of the half-life of the medication, the concentration will drop too low and it will not have the desired therapeutic effects. So what does the evidence say about a particular drug for a particular patient, for a particular disease condition, even for a particular setting? So we synthesize this evidence and we use it in our discussion with other healthcare professionals that we want these patients to receive this at this time because that is what will help us to optimize the benefits, the outcome for the patients. So the evidence becomes very important in order for us to continue to provide the kind of service that is required of us as clinical pharmacists. So what are the strategies we can adopt? The strategies flows around continuous professional development. You see, seminars like this, workshops like this, conferences like this, they are top-notch. They help us to update our skills. Not only that, they help us to come in touch, in direct contact with the latest evidence that research is churning out. Now, evidence-based practice should be in our curriculums in our school so that even before the student comes in contact with practice, they are already getting some form of comprehensive training that make them understand the principles and the methodologies that they need to be familiar with in order to optimize treatments for their patients. Clinical databases. How do we access these databases? What is the best way to search these databases in order to have information that has been critically examined? All this becomes important in order for us to establish an evidence-based practice. Now, if you have an evidence-based practice, the difference between two practitioners when attending to the same condition should not be so wide, especially if the characteristics of the patients they are attending to are the same, in order to see that the same clinical consistency is applied to the same type of patients. Standard operating procedures need to be put in place. This is outside developing a proper clinical guideline, okay? Standard operating procedures need to be put in place, okay? And we should have an improved working relationship with other healthcare practitioners and make them to understand that the decision we make is evidence-based as far as healthcare is concerned. So clinical rounds, are we there? We should be there so that other healthcare practitioners need to start getting used to seeing our faces. Decision support systems. Yes, I've mentioned this a lot with mobile apps and so on and so forth. We should start using them. We should start looking at the evidence that are available, okay, and deploy them. Then on our own, we should conduct our own research so that we can generate new evidence that assists in promoting the information that is out there. At the same time, the quality of practice that we have, are we satisfied with it? So we begin to now generate patient outcome data that supports the services that we are providing as clinical pharmacists, showing that yes, our intervention is evidence-based, and this is the new innovation we are bringing into play in order to improve what we are doing before. So we need to get involved in quality improvement projects as well. So on this note, I would like to conclude as follows, that if we embrace innovative approaches in providing evidence-based pharmacy practice, we will indeed improve outcome for patients, we improve the safety that patients have. At the same time, we will be able to improve our own job satisfaction, okay, in a way that will be beneficial to the healthcare system and to our country at large. I thank all of you for listening. Thank you. So I will take some questions.
Round of applause for Professor Tony Waka Udeze. He had a lot to say as a professor of clinical pharmacy and pharmacy practice with expertise in pharmacoeconomics, drug therapy, and health outcome. You all would agree with me that it is just to the topic given to him, innovative approaches to advancing evidence-based pharmacy practice. And he let us know that in talking about evidence-based pharmacy practice, there is need to pay attention to adherence strategy. And the ultimate goal, therefore, is to improve the quality of patient care. He took us through a lot. Digital tools, telemedicine, video conferencing, blockchain, virtual reality, a lot. And he let us to know that it's not just to train pharmacists, but also to help patients to understand the why, the how, and the when to take their medication. And he added by saying that it requires multidisciplinary collaboration. And he gave us a recommendation that evidence-based pharmacy practice to be incorporated into pharmacy education. Another round of applause for Professor Tony Waka Udeze. It's now time to present the plaque. We have one question for him. We have a question for you, Prof, before the presentation.
Yes.
Okay. He says, thank you for the rich presentation. Please, with respect to pharmacogenomics, you mentioned some group of genes that drugs can interact with to prolong and improve quality of life. One, can you reiterate this by mentioning the kinds of proteins you gain, how it works, and cases where such interventions have been used before, especially to prolong life? The second question says, what are the indices used to know if life has been prolonged with such technology? That is, how would you know that the lifespan of a given user has been prolonged? Thank you, sir.
Okay. Okay. Now, Dr. Sinclair at the University of Harvard is in the forefront of this type of research. He has used animal models to look at the different sirtuins and which one of them has the potential of prolonging life. And I can give you some specific drug molecules. Tuarine has been found to prolong life by 22%. And they are planning clinical trials in humans. And it has also been found that even in humans that take tuarine, the mitochondria becomes the mitochondria become more efficient. And when mitochondria become more efficient, they are able to put out more energy for the particular individual to use. There is also research about L-carnosine. L-carnosine is a dipeptide that has also been found to improve the activity of mitochondria. When the activity of mitochondria is improved, there is the increase in the utilization of fats. So more fat is likely going to be burnt, and the weight of that individual is going to be controlled. And parameters such as blood glucose concentration, reduction in inflammation, reduction in blood pressure has also been found as a result of this research as well. So there are several molecules that are there. There is a fucoidiene. Fucoidiene was extracted from seaweed. It has also been investigated for its ability to interfere with certain hormones in the body in order to promote the lifespan of individuals as well. So David Sinclair is on the forefront of this kind of research. Thank you.
Round of applause for Professor Tony Waka-Okezie. It's now time to present him the certificate and plaque. And this will be done by Dr. Thank you. This will be done by Dr. Chukwuemeka Azubike. Thank you.
Very impactful one. On behalf of the Impact Pharmacy and the organizing committee of this conference, I present the award to Professor Anthony Waka-Okezie for his thank you very much. And
my pleasure.
I believe that next time we thank you for representing University of Guinea very well. And I will ensure that you get to Guinea.
Thank you. Yeah. Thank you. Thank you very much. I deeply appreciate.
Professor, before he leaves, thank you so much. You all can agree with me that all us actually experts in empathy. And thank you all for the reason that on this call for staying to the time that you are enjoying the lecture. It has been intimidating, informative, rewarding, thought-provoking, illuminating, and profoundly impactful. Another round of applause for all our speakers. It's now time for the parallel test. Before then, we're going to take the oral presentation. And I want the oral presenters to be ready, but after the presentation, we're taking two oral presentations. And at the end of the second presentation, questions will be taken by each presenter as they come. So kindly, as the discussion is going on, kindly take your questions to the platform. We are taking the first oral presentation. And abstract number 007, and raising. After that, we are taking abstract number 034. Dr. Amina Tayawalija. So, annotated raising for the first presentation, and Tayawalija for the oral presentation. Thank you.
Greetings to all participants in this year's third Faculty of Pharmacy Conference holding at the University of Lagos, Lagos State. My name is Anosike Chibueze, and I'm here to make a presentation of our work entitled Impact of Educational Interventions on the Attitudes and Practice of Community Pharmacists toward Providing Pharmaceutical Care for Clients with Depression in Southeastern Nigeria. Now, the background of the study. As of 2017, the World Health Organization estimated that about 280 million people suffer from depression. However, out of these 280 million people, Nigeria accounted for about 7 million So the burden of depression is quite high in Nigeria, but then the availability and access to mental health services remains very poor. However, community pharmacists, being one of the frontline healthcare workers who are readily accessible within and around their communities, will have a role to play in providing mental health services for individuals with depression. For example, they could screen such clients, they could provide counseling, monitor their drug therapy, and even refer them to mental health care professionals whenever necessary. However, pharmacists' potential in this regard in providing care for individuals who are depressed have been underutilized due to lack of mental health training and education. Therefore, this study aimed to assess the impact of education interventions on the attitude and practice of community pharmacists toward providing pharmaceutical care for patients with depression. The methods. This study was a prospective pre-post interventional study conducted among currently licensed community pharmacists in Enugu and Awka. Sample size required for the study was 257. The educational intervention administered in the study included a 10 to 15 minute face-to-face discussion with each pharmacist, sharing of information, leaflet, and online resources focused on depression and its management, symptoms, common beliefs and myths, pharmacists' role in managing depression, and pharmaceutical care activities in depression. Data in this study was collected using validated attitude towards providing pharmaceutical care and depression care practice questionnaire, which were administered before and after the intervention. Data collected were analyzed using descriptive statistics and paired sample t-tests. This study got approval by Ethics Committee of the University of Nigeria Teaching Hospital. Now the results. Table 1 shows pharmacy social demographic characteristics. Our findings show that more than half of the participants were male pharmacists. However, overall, there were no differences in their social demographic characteristics in both the pre-intervention and post-intervention group. Table 2 shows the impact of education intervention on attitudes and practice. Our finding shows that educational intervention improved community pharmacists' attitude toward providing pharmaceutical care services for patients with depression. However, our intervention had no effect on their level of practice. Tables 3 and 4 shows the predictors of attitudes and practice. Our findings reveal that pharmacy managers were more likely to have positive attitude toward providing pharmaceutical care services than superintendent pharmacists. Similarly, pharmacists who are based in Enugu, having a Master's of Pharmacy degree and being a pharmacy manager, they are more likely to provide good pharmaceutical care services compared to pharmacists based in Awka and those who have B.Pharm or PharmD degree and superintendent pharmacists. In conclusion, our educational intervention improved pharmacists' attitude toward providing pharmaceutical care services for patients with depression, but had no significant effect on their level of practice. Pharmacy managers were more likely to have positive attitudes compared to superintendent pharmacists. However, being a pharmacist based in Enugu, having M.Pharm degree and being a pharmacy manager were predictors of good pharmaceutical care services towards people with depression. We therefore recommend mental health training to enhance pharmacists' competence in caring for persons with depression. These are my references. Thank you for listening.
A round of applause for the first oral presenter. Now it's time for the second oral presentation.
Good day, everyone. My name is Abina Sayawaluja, presenting answer reference number FPC 2434, titled PPR Alpha and Gamma Activation Effect of Inhibitors and Lignans, attended from the leaves of Nephilipase Zotata, family Nephilipase. Pyroxene polypeptide receptor PPARs are a member of nuclear hormone receptor superfamily that plays an important role in genetic transcriptional control of human cellular processes, including lipid metabolism glucose homeostasis, and cell cycle progression. Three isoforms exist: the alpha, beta, and the gamma. The alpha regulates lipid metabolism and modulates inflammation. The beta participates in embryonic development, implantation, and bone formation, while the gamma is a key factor in adipogenesis, insulin sensitivity, cell cycle regulation, and cell differentiation. They are responsible for insulin sensitization. They play an essential role in renal physiology as they are present in various parts of the nephron, including the distal convoluted tubules, the proximal convoluted tubules, the Bowman capsule, the collecting dose as indicated in figure 1. PPR alpha is a drug target for diabetic agent, while the gamma is for lipid-lowering agent. Compound that has dual effect on both alpha and gamma play a key role in prevention of progression of renal damage. Chemical investigation of ethanol extract of N-azotata resulted in isolation of lignans and iridoids. The structures were elucidated using photoscopy method. The beta gene assay was used for the determination of PPR alpha and beta agonist effect on EBD2 cells. The cells were transfected with either PPR alpha or gamma and plated on a plate of density 5 times 10 to the power minus 1 cells per well in a 96 real tissue and cultivated for 24 hours. After 24 hours incubation time, the cells were lyzed and the spread activity was measured using the spread assay system. Fold increase in the spread activity of sample treated cells were calculated in comparison to the vehicle treated cells. The sample analysis was used to determine the protein expression and cell variability were also carried out. Figure 2 shows the structures of isolated compound from the ethanol extract of N-azotata. Compound 1 to 3 are iridoids, while compound 4 and 5 are lignans. Lignans are monoterpenes of cyclopentanol ring, while the lignans have 2 phenyl-propanol unit linked by beta linkage. Table 1 shows the PPR activity of selected compounds. For the result to be of significance, there must be a fold increase of greater than 2 over the control, while the cell variability as result was shown on the last column. Figure 3 shows the effect of compound with dual PPR expression done by the Western blot analysis. The A is for the alpha, while the B is for the gamma. The 5 compounds have dual PPR alpha and gamma activity, and none of the compound was toxic to EBD2 cells. In conclusion, compound extracted from the leaves of ethanol extract of N-azotata has dual PPR alpha gamma activity, indicating their potential to maintain the integrity of the kidney. A selected compound has a fold induction of 2.0 over the control. The compounds were non-toxic to EBD2 cells and cell variability were greater than 80% for all the compounds emitted. So therefore, the dual PPR alpha gamma agonist activity of the compound extracted from N-azotata was established, indicating their ability to prevent deterioration of renal function. These are my references. Thank you for
Applause
listening.
for the second oral presenter. A round of applause. Thank you so much. Now it's time for questions. Kindly turn on your videos, presenter 1 and 2. Questions for Anosike Chibeze. Any questions? Can I read your signal hand? Any questions? Abstract number 007. Turn on your video. Thank you. Any questions for Anosike Chibeze? Okay, we go to the second presenter. We have questions for Ayawaluja Amina. That's all. Abstract number 034. And raise your display hand and we will move to speak. If you want to ask questions. Or you can type it into questions and answer box. Okay. In the absence of the question, please unmute and speak. And who are you directing the question to? Chibeze Anosike. I read the question. Please. Are you ready? I'm not abstract number 007. The question says, congratulations to the two oral presenters. For presenter 007, why is your T-test value negative? Having shown responsibility.
All right, thank you for the question. T values generated in the analysis, that is what we did was first sample T test. Remember that the T values can either be a positive value, but the difference is significant or not, as shown on the table.
I'll say it again. The line was breaking, please. I'm not thinking, please. You can respond in the chat box as well. Now, any questions for the second presenter? Yeah, we'll do that in another talk. Any questions for the second presenter? Another round of applause for the oral presenters. It's now time for the parallel session. We are taking the poster presentation and give us the breakout session rules. I'll call on Dr. Nicola Oseni, tell us the different breakout rules and rules. Thank you.
Good afternoon, participants. Thank you for staying with us. So we'll be going on to the poster presentation section now. And for that, we have 5 breakout rooms. So we have labeled the 5 breakout rooms to 1, Farm and Farm Tech. We have Clean Pharmacy, Pharmacognosy, Pharmaceutical Chemistry, and Farm Micro. I repeat, Farm Chem, Farm and Farm Tech, Pharmacognosy, Clean Farm, and Farm Micro. Please, we enjoy all participants to kindly join any breakout room of their choice. You can see the icon for the breakout room usually below your screen or by the side, thanks, or on top. So you see the icon for breakout room. Kindly join the breakout room of your choice. However, if you're finding difficult to join the breakout session, kindly type in the chat box and we will respond to you. Thank you. So we can all now join the breakout rooms of our choice. Enjoy your presentation. Thank you.